Welcome to Dr. Balaga's podcast for the Curious Doc. Today is July 2nd, 2026. This video is on an 2026 ACC Scientific Statement titled Antiplatelet Therapy in the Management of Atherosclerotic Cardiovascular Disease. This is a report of the American College of Cardiology. These are some abbreviations for the non-cardiologist. What is the central message? Antiplatelet therapy remains essential for atherosclerotic cardiovascular disease, but benefits must be individualized against bleeding risk. Is aspirin still central? Yes, aspirin remains widely used, especially for secondary prevention and peri-procedural therapy. Is aspirin routine for primary prevention? No. Routine use is unsupported in unselected populations. Consider only high ischemic and low bleeding risk patients. What changed over the last decade? Drug-eluting stents, potent P2Y12 inhibitors, shorter dual therapy strategies reshape practice. What does the statement emphasize? Current guidance, guideline alignment, special populations, surgery, monitoring, and adherence. Why was the statement written? To provide consensus guidance where antiplatelet evidence is evolving or guideline details are limited. What disease spectrum is addressed? Atherosclerotic cardiovascular disease, including coronary, cerebrovascular, and peripheral arterial disease. What is the recurring clinical tension? Preventing ischemic events while avoiding clinically meaningful bleeding. How are recommendations developed? This ACC writing committee reviewed key literature and resolved content by consensus. Was commercial input involved? No. The work was supported by the American College of Cardiology. The committee members were unpaid volunteers. What is BARC bleeding? It's a standardized scale from no bleeding to fatal bleeding used commonly in antiplatelet trials. What counts as clinically significant bleeding? BARC type 3 bleeding includes transfusions, intracranial bleeding, or a hemoglobin drop of 3 to 5 grams per deciliter. What is high bleeding risk? HARC-HBR identifies PCI patients at increased 1-year risk of major bleeding or intracranial hemorrhage. What is de-escalation? Reducing antiplatelet effect by changing drug type, dose, or number of agents. What is MACE? Usually cardiovascular death, myocardial infarction, or stroke. Some trials add revascularization or unstable angina. Why target platelets in atherosclerotic cardiovascular disease? Platelets drive thrombosis, endothelial responses, inflammation, and atherothrombotic complications. How large is the ASCVD burden? The statement cites high prevalence of CAD, stroke, peripheral arterial disease, and recurrent MI or stroke. Which antiplatelet classes are central? Aspirin, of course, P2Y12 inhibitors, and glycoprotein 2B3A inhibitors. With newer agents under study, what is the therapeutic aim? Suppress pathologic thrombosis without causing unacceptable bleeding. Why is individualized therapy necessary? Ischemic and bleeding risk vary by clinical presentation, comorbidity, anatomy, and time from event. Pharmacology of commonly used antiplatelet agents. How does aspirin work? It irreversibly inhibits platelet cyclooxygenase 1 and thromboxane A2 formation. How do P2Y12 inhibitors work? They block adenosine diphosphate mediated platelet activation through P2Y12 receptor. How does clopidogrel differ from prasugrel? Both are prodrugs, but prasugrel produces more complete and consistent platelet inhibition. What is distinctive about ticagrelor and cangrelor? They are reversible non-thienopyridines. Cangrelor is intravenous with very rapid onset. Why combine aspirin and P2Y12 inhibitor? They inhibit distinct pathways, producing strong platelet inhibition as dual antiplatelet therapy. Evolution of DAPT regimens. Why was prolonged DAPT once favored? First generation drug eluting stents carried a high stent thrombosis risk than bare metal stents. Why are shorter regimens now plausible? Modern stents, imaging guided PCI, and potent P2Y12 inhibitors have lowered stent thrombosis risk. What is the modern focus? Reduce bleeding while preserving ischemic protection after PCI or acute coronary syndrome. What follows short DAPT in many trials? Aspirin monotherapy or P2Y12 inhibitor monotherapy after 1 to 3 months of DAPT. What are contemporary stent thrombosis rates? This statement notes rates as low as 0.4% to 0.5% at 1 year and under 1% at 5 years. Summary of current clinical practice guideline recommendations. What is default therapy for ACS? For patients without high bleeding risk, DAPT for 12 months remained default strategy. What is default therapy in medically treated chronic coronary disease? Low-dose aspirin is the default unless contraindicated or another strategy is selected. What is the default therapy after PCI for chronic coronary disease? Aspirin plus clopidogrel for 6 months followed by single antiplatelet therapy. When is short DAPT reasonable? Selected patients may receive 1 to 3 months of DAPT followed by P2Y12 inhibitor monotherapy. Do the ACC, AHA, and ESC recommendations fully align? They broadly agree but differ on details such as prasugrel preference over ticagrelor in ACS PCI. Ischemic versus bleeding event risk. What happens when antiplatelet potency increases? Ischemic protection usually increases, but bleeding risk rises in parallel. When is thrombotic risk highest? Immediately after an acute ischemic event, then it declines over the first month. Which features raise ischemic risk? Acute coronary syndrome, complex PCI, recurrent stroke, and recurrent acute limb ischemia. Which features raise bleeding risk? Advanced age, prior stroke or bleeding, renal dysfunction, low weight, anemia, and female gender. How should calculators be used? DAPT, precise DAPT, ARC HBR, and S2 top bleed can help but cannot replace clinical judgment. Antiplatelet therapy in primary prevention of major cardiovascular events. What is aspirin's primary prevention benefit? It modestly reduces MI and stroke but increases major bleeding. Does aspirin reduce all-cause death in primary prevention? The statement notes no all-cause mortality reduction in major primary prevention analyses. Who might be considered for aspirin? Adults 40 to 70 years with high-risk atherosclerotic cardiovascular disease risk and no increased bleeding risk. Who should generally avoid routine aspirin? Adults over 70 years and patients with high bleeding risk. Can coronary artery calcium or Lp(a) guide aspirin? They may refine ischemic risk, but randomized aspirin trials in these enriched groups are lacking. Antiplatelet therapy post-revascularization. What is the default post-PCI duration? 6 months for chronic coronary disease and 12 months for acute coronary syndrome. Which P2Y12 inhibitors are preferred in ACS PCI? Prasugrel or ticagrelor are preferred with some data favoring prasugrel. When is clopidogrel useful? When potent P2Y12 inhibitors are unavailable, contraindicated, not tolerated, or bleeding risk is high. What about older patients? Clopidogrel may be favored after age 75 because prasugrel and ticagrelor increase major bleeding risk. Should aspirin be maintained around PCI? Yes. The statement emphasizes maintaining aspirin during the peri-PCI period. De-escalation after PCI and ACS. What is shortened DAPT? 1 to 3 months of DAPT followed by P2Y12 inhibitor monotherapy. What benefit does shortened DAPT offer? It can reduce bleeding without increasing ischemic events in selected patients. Which agents have strongest data for monotherapy? Ticagrelor has the most robust evidence. Prasugrel has emerging support. When may switching to clopidogrel be considered after 1 month in selected ACS PCI patients to reduce bleeding risk? Where is caution needed? In high ischemic risk patients, especially STEMI or complex thrombotic presentations. Long-term antithrombotic therapy beyond 1 year. What is the long-term aspirin dose favored? Low dose with 81 mg commonly favored for tolerability and adherence. Is clopidogrel a long-term alternative? Emerging data suggests clopidogrel monotherapy may outperform aspirin with similar or lower bleeding. When is prolonged DAPT considered? In selected patients with high recurrent ischemic risk and low bleeding risk. When is rivaroxaban plus aspirin considered? For selected high-risk stable CAD or PAD, peripheral arterial disease, patients without prior major bleeding or cerebrovascular accident. Why is long-term therapy individualized? Net benefits depends on recurrent ischemia, bleeding risk, prior events, and patient values. Post-CABG antiplatelet therapy. What is standard after CABG? Aspirin should be continued or restarted promptly once bleeding is controlled. Does DAPT improve graft patency? It reduces vein graft failure but has limited clinical outcome benefit and increases bleeding. What happens after ACS requiring CABG? DAPT is generally resumed post-op when safe and often to complete ACS-directed therapy. When may DAPT after CABG be considered? In selected patients at high risk of graft occlusion and low bleeding risk. What is the key CABG principle? Aspirin remains foundational. Additional therapy needs an ischemia versus bleeding rationale. Peripheral artery disease. What role does antiplatelet therapy have in PAD? It is important in acute and chronic management, similar to coronary disease. How does PAD revascularization differ from PCI? DAPT durations are usually shorter, typically 1 to 6 months after revascularization. What long-term strategy is reasonable in PAD? Low-dose rivaroxaban 2.5 mg twice daily plus low-dose aspirin can reduce MACE and limb events. Who is best suited for intensified PAD therapy? High-risk patients with acceptable bleeding risk. What is the caution? Major adverse limb and cardiac benefit must be weighed against bleeding risk. Stroke and TIA. What is recommended for minor ischemic stroke or high-risk TIA? Early aspirin plus clopidogrel within 12 to 24 hours, continued for 21 days. Which minority stroke severity is referenced? NIH stroke scale score of 3 or lower. Which TIA risk threshold is referenced? ABCD2 score of 4 or higher. Why stop DAPT after the short course? Therapy is de-escalated to monotherapy to limit bleeding risk. Where is the evidence unclear? Patients receiving thrombolysis are those with more severe strokes. Valve disease and oral anticoagulation. How are bioprosthetic valves managed long-term? Single antiplatelet therapy, typically low-dose aspirin, can be used long-term. What is the principle for patients needing oral anticoagulants after PCI? Avoid prolonged triple therapy because bleeding risk is high. When can aspirin usually stop after PCI with oral anticoagulants? Often within 1 month, leaving a DOAC plus clopidogrel. Which agents are favored with oral anticoagulants? DOACs and clopidogrel are generally favored. What about therapy beyond 1 year? Direct oral anticoagulant DOAC monotherapy may be appropriate in selected patients. Perioperative management of antiplatelet therapy. When should elective surgery be deferred after PCI? At least 6 months after PCI for chronic coronary syndrome and 12 months after PCI for ACS. What is continued after the deferral period, low-dose aspirin is generally continued while P2 white valve inhibitors can be stopped. When is clopidogrel stopped before surgery? About 5 days before surgery. When are ticagrelor and prasugrel stopped? Ticagrelor stopped 5 days before surgery and prasugrel stopped 7 days before surgery. What about urgent surgery? It may require P2 white valve cessation, bridging with short-acting IV therapy, or platelet transfusion in emergencies. Why monitor beyond prescription? Response, bleeding, adherence, drug interactions, and tolerability vary substantially. Is routine platelet function testing recommended? No, it's not universal, but may help guide P2 white valve de-escalation in selected cases. Is genotyping recommended? No, it's not universal, but may be useful in selected clopidogrel-related decisions. When is PPI or proton pump inhibitor recommended for high GI bleeding risk or concomitant anticoagulant use? Does omeprazole clinically negate clopidogrel? The statement notes that clinical harm from this interaction has not been proven. Adherence to antiplatelet therapy. Why is adherence critical after MI? Early non-adherence after PCI is linked to stent thrombosis and major adverse cardiac events or MACE. What factors reduce adherence? Older age, polypharmacy, socioeconomic barriers, high cost, bleeding, and dyspnea. What follow-up timing is helpful? Early post-discharge follow-up, ideally within 6 weeks, can address adverse effects and barriers. What interventions may help? Culturally sensitive education, cost mitigation, side effect management, de-escalation, and multi-level support. What is the polypill concept? Fixed dose combinations may improve adherence, but evidence remains an active research area. Evidence gap and future directions. What remains the major limitation of antiplatelets? Bleeding risk remains the key constraint on intensifying therapy. What would an ideal antiplatelet do? Prevent thrombosis while preserving normal hemostasis. Which novel pathways are being studied? GPBI, 1 milligram factor GP1B, PAR4, P2Y receptors, intracellular kinase, BTK inhibitors, Bruton tyrosine kinase inhibitors, and protein disulfide isomerase. Which injectable agents are highlighted? Selatogrel, a subcutaneous P2 white valve inhibitor, and zalunfiban, a subcutaneous glycoprotein inhibitor. What future questions remain? Optimal DAPT after modern DES stents and drug-coated balloon, drug-eluting stents and drug-coated balloons, and whether precision algorithms can personalize therapy. This is a fantastic document. Go ahead and read it. It's open access. This is an infographic. Hit pause and read it at your leisure. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.